we, the panel members that prepared this document, that we listen, that we have as much as possible input from your side. You are the stakeholders that invest the effort to come here. And in order to have a feeling about the extent to which this document really can make an impact, we have to hear from you what your feedback is. That feedback will be integrated, of course, in a common negotiation with all panel members at our meeting at 20th of November. And then the document will be finalized and the final version will be put on the website and distributed and printed and made available. So the aim is that we capture your input, your reflections. The panel members here actually are Ales Burek from Czechia, Lasse Lehtonen from Finland, Werner Brouwer from the Netherlands, and Lubna Muroskiene from Lithuania. I think that's all. And then, of course, also we have Katja Saranto from Finland, who is an expert also and whose input was very much appreciated during the process. So we are responsible for the document as it stands now. The challenge is to improve it, to bring in your voice. This hearing will be web streamed, so of course that will make it possible also to look afterwards how well you performed, all of you, so and to also inform other people that they can have a look at it in case they were unable to attend. I propose that we start with giving an overview, and Ales Burek is going to take the floor. I want already to ask you now that as everything is web streamed, we ask you to use the microphone for the debate, and whenever you take the floor, present yourself, your name, your country, your background, so that the people who make the report in the back of this room, that they can capture really what the input is and who is the author of the input. Thanks already for taking care of that. So I would like to give the floor now to Alex, please.
Thank you, Jan, for the introduction. Good morning, ladies and gentlemen. It's a great pleasure to be able to present the work of the expert panel on an issue that in the beginning of the year we thought would be as easy handleable as all the other issues, obviously, that we get from the Commission. And it turned out to be an extremely interesting exercise. This is the group that is responsible for this report in the stage that it is, and as our chair said, we are very much looking forward to getting inputs from you how to improve the job that we have tried to manage as best as possible. There are several issues related to the term of reference, and the term of reference is obviously easy said, hard done, because in principle the interest is to define ways and needs of evaluating the effects of changes that are happening throughout the society and are in principle basically the result of a natural revolution, the going from the industrial society into the information society. And the impact we've seen basically in all areas of human activities. To show you how difficult the issue is, we were astounded ourselves. This concept tree was produced based on 400 pages of documents provided by a pristine computer with no history, so that Google would not basically manipulate it towards our needs. And the 460 kilobytes of free text, the first 400 web documents, showed the broadness of all scales ranging from micro to meso to macro level concerning health, ranging from purely technical aspects like technology and wearables and mobile technology, to very personal and societal effects of personal privacy, scanning of people. You may be aware that today we have technologies that basically are capable of scanning the thoughts. Functional magnetic resonance is at a stage where basically the digital technology is able to reconstruct the thoughts. When I used to lie as a young person, nobody would find out if I did it well. Today you have near-infrared thermovision, which basically visualizes the circuits inside your head. So there are many issues, and the complexity is underpinned by the situation that there is a time shift. So assessing the digital impact on health services shows all the aspects of a complex system, polythery, different goals that we have to address, time-wise shift, and all scales going from personal level to the whole societal level. To show it even possibly more explicitly, rather than going to concepts, let's go to terminology, and you see that the transformation addresses technology and systems. It goes through networks and the industry, and it ends up in customers and security. So it really is rather a very broad issue, and finding common ways of measuring the impact is, let's say, at least an intellectual exercise, hopefully something that can be done. We are optimistic in that way. What we are also seeing is that as our technologies shift, and as the society shifts from the feudal society into the industrial society, and later into the information society, it also addresses the way how we understand what actually is a health service. When it started on the level of one healer and one sick person, we didn't need to collaborate. It was a one-on-one affair, and it was played on direct data, whether explicit or tacit. Then we moved into the industrial society, and the vision of seeing the human body as a perfectly functioning machine resulted in descriptive medicine. We took apart the whole individual into pieces. So one part was for the neurologist, the second part was for the surgeon, and the third part for the urologist. And the industrial society resulted exactly in healthcare as it resulted in all other areas. We needed a factory to produce, and the factory used to be called the clinic. And all of you might remember the situations when the top of medicine was performed at a clinic. That's where the machines were. That's where we were able to be productive. And then as we gradually turned the industrial society roughly around 1990, it started converging into the information society. Dramatic changes have happened all across the society. From the descriptive medicine, we went into experimental medicine, and today we are seeing a shift into causal medicine. Basically, the ideal of Chinese medicine was to keep the people healthy, and the physician was paid only as long as the person he was caring for was healthy. This was unattainable in the type of medicine that we used to practice in Europe, because essentially our medicine was the type of medicine that cured. We had to diagnose and we had to cure a disease. And for the first time in human history, essentially we have in our hands the type of medicine that can do proactive, preventive, and prospective care. So apart from shifting in technologies, we are actually also shifting in the process of care, going from simple disease management through assisted care, which is a term invented by the lay community, where they started to participate with the healthcare professionals in the service provision through shared care, where it's almost 50-50, where the patient themselves collect a lot of facts and then require a professional to discuss the available facts in order to make the appropriate decisions, but from the point of view of the people that we are actually serving, and moving more into the process of prevention, self-help, and public health, moving from hospital-based to outpatient-based, which is today a dominant way of providing many of the services, into telemedicine, providing some services at a distance, but obviously not those that cannot rely on data that cannot be turned into the digital format, and moving into cyber medicine. Previous generation of doctors basically were treating human individuals. Today, the professionals are often in front of a mixture of human and technology, basically treating cyborgs. Somebody who has a pacemaker on demand partly is a human, partly is a machine system. And these challenges obviously happened with the introduction of the digital into today's way of doing things. Why we are sometimes not seeing the results we would expect. 30 years ago, everybody was talking about a paperless office. And 30 years from that time on, we still see paper in the offices. 10 years ago, we had the idea that normal printed books would be phased out by e-readers and e-ink, and it has not happened. So, in a sense, we have to bear in mind that progress is a result of an interaction of the people that are the main drivers, of the processes done, of the power that we have at our disposition, and of the tools. And across the history, all of this has changed. The power as such has changed only 4 times in history, from manpower to horsepower to steam engines and to electricity. We are still electric-based, even though we have moved from the industrial society into the information. What we have changed is the process of doing things. In the last 30 years, we have, in general, in the whole society, made a lot of effort to turn all that makes sense into digital code. This is what we refer to as digitization. That's basically changing the data or information into digital format. We do that for a very good reason. Basically, all of the history, we relied on storing. We tried to store food, and we tried to store information or documents. And every time we stored these things, they started to corrupt, to go bad. So the progress of humanity is based on how well we are able to store stuff so that people can take up from a position that somebody has already done. In order not to reinvent the wheel, somebody has to describe what a wheel is, what the functions are, and then somebody can come and put 4 more wheels or 3 more wheels to make a cart, and then somebody stores what a cart is, and somebody develops how to make that cart even more functional. This is what is happening, and so trying to assess the digital impact or the impact of digital technologies on a health service essentially means also addressing the people and their behavior, and also addressing the processes that have happened. Look at the agricultural revolution. It used to require almost everyone to work in the field to produce the food so that we would survive as humans. Then with the advent of farm animals and of using the horsepower, we could do this much more efficiently, but instead of using the spade to dig in the garden, we had to start doing things differently. And this is essentially what we are seeing today in the health sector. When we talk about health services, it's not just about introducing technologies, but in a sense, it means changing the way of working. And as we all know, substituting a typewriter for a computer, if the physician still uses 4 fingers to type, doesn't make much of a difference when it comes to providing services. These are issues that have to be handled when we are trying to assess what is going on. Obviously, the difficulty of the situation always lies also in understanding what can be done digitally and what has to be done in the real world. Now, to adapt for situations in the real world, we've had tens of thousands of years as humans. For adapting to what has happened in the virtual world, we've had the last 30 to 40 years. In order to teach us how to behave in the real world, we have our instincts, we have our reflexes, and essentially most of the stuff in the real world is evident. I can see things in the real world with my eyes. Also, a lot of the issues happening in the real world can be addressed by common sense, as opposed to the virtual environment that essentially we have constructed, but Mother Nature has not prepared us to live in very well. And it would be an easy task if we could behave in the real world exactly the same way as behaving in the virtual world. But let's say that in the real world, my mother used to teach me to use my eyes to find things. And to find something in a written text, I had to stream through the text with my eyes. And we had our ways of doing that, let's say quick reading. When going into the digital world, I still see a lot of doctors trying to find out something in the digital text with their own eyes, instead of going Control F, F3, or asking Siri to find the issue. And this continuous going there and back between natural behavior and the behavior requested in the virtual world doesn't do us too well. We have been prepared by Mother Nature for the quickest change, and that's the 24-hour cycle of day-night, day-night. I think that everyone in this room understands that we walk into the office and we have to behave naturally, greet the people, shake hands, tell them how we're fine being with them and how it gives us a kick that we are able to play emotions, and then we spend 20 minutes doing Control F, Control C, Control V, then we are back into normal, trying to behave normally, and back for 20 seconds there, and this continuous switch has its toll. The toll is actually measurable in the amount of antidepressive drugs taken. For example, in the Czech Republic, we have 600,000 psychiatric diagnoses in a population of 10 million people, and that's obviously the top of the iceberg. So in order to assess the impact of the digital environment, we must be aware of all of these factors. The other very important aspect is that if I do something wrong in the real world, I usually see the effect. If I cannot use the hammer properly, I hit my finger, it hurts and it bleeds. So the effect is obvious. But when we are doing things in the virtual, in the digital environment, this may not be so obvious. And even companies where one would expect that they do understand what is the digital, because they have actually been the foreleaders, whether it's Google, whether it's Facebook, there are surprises when they find out that they haven't done something as well as should have been done. And it doesn't have to be WikiLeaks, it doesn't have to be Google+, and it doesn't have to be what happened on Facebook not so long ago. So the virtual world obviously presents opportunities, but also bears some substantial risks. And when it comes to assessment, we have to take this into consideration. Again, we are talking about the impact of digital on the health service as such. Then we have to take into account that we are talking about an interaction of two extremely complex systems. One is called health care, and the other is called the digital or the information society. Now, when two complex issues interact, we should be expecting unexpected. And these are emergent things that happen because there is this interaction between two complex systems. And this has been demonstrated before that the interaction of two complex systems has its advantages, but also has its drawbacks. And the non-predictability, non-controllability of decentralized systems is something that we have to acknowledge will affect the way how we provide health services. To make things even a bit more interesting, when it comes to health services, we see an interaction of the processing of code which can be turned into digital format, and that's essentially in all of the 6 areas voiced on, from your perspective, the left side of the screen. When it comes to biosignal processing, we don't have an issue. That's a dominant place for digitalization and for introducing this into the health service. When it comes to digital imaging, 90% or at least 80% of hypotheses of diagnosis are rejected today based on digital imaging. 3 decades ago, the professional had only 2 ways of looking into his brother and sister in need. Either probatory laparotomy, cut the person open, or use harmful X-rays. And this has been considerably changed with the advent of digital imaging technologies, many of them being without harmful side effects as the X-rays were. Obviously, another area where using the digital code in the health sector is very welcomed is in the communication. All of us who have played silent whisper games knows what happens if we use non-digital communication. The level of noise and the level of disinformation vastly increases. There are also strong chances of using the digital code in areas like making spare parts for the humans. Using the old approach, we went from form to function because we did not know what the function would be. It had to be tested, and then in iterative changes we had to improve the spare part, whether it was an artificial valve or a hip replacement. Today, the digital way of doing this allows us to go from function to the optimal form. So generally speaking, we can put the data into the computer and then have the algorithm model the optimal shape. And once this is done, it can be either sent to a CNC machine or to a 3D printer. So the turnover rate of producing spare parts, individualized and well-functioning, is much quicker. And that, again, is an area which is most welcome when it comes to the digital impact on healthcare. I think that as a group, when we did this exercise, we agreed that the biggest impact of the digital health services lies in totally changing the functions of people collaborating on improving the health of the people. We still remember the times when the person who knew was the professional and the layperson was the one who did not know. Obviously, these people did not know because they didn't have a chance to know, because they didn't have access to the professional libraries. Nobody would allow them to go to perform autopsies, and all of these issues are handled digitally. Instead of going to a library, anyone can pull the National Library of Medicine towards themselves. Basically, all of these resources are free, and the role of the professionals have changed due to the impact. The professional is not there to provide the facts anymore. The professional is there to weigh the options, do best possible reasoning with available evidence-based information on behalf of the person who requires this service, and then together with this person arrive at the best optimal solution, but not from the point of view of the professional, but from the point of view of the care receiver. And that's where we start talking about goals-oriented care. So due to these issues, not to speak about telemedicine, which means a service provided at a distance, which does make sense in many situations, and we are able to see many situations today when, if the health service provider is on the other side of the world, he is able to help better the client of this service than when he is standing next to him, whether it's teleconferencing and teleradiology, where the best experts are able to evaluate the digital images, or whether it's robotic operation, where the best specialist is able to provide the care. On the other hand, in situations where direct person-to-person interaction is necessary, I could never imagine supporting an oncology patient at a distance when this person possibly wants to be held by the hand. So there will be opportunities and there will be issues where to do things in the right way, and that means digitally. And there will also be situations where the non-digital approach, the analog approach, will have a dominant position. There are also some specifics why we are unable to transfer directly our experience from other industries and other services into the healthcare sector. Now, if a money broker does the job wrong due to the digital technology breakdown, the worst thing that can happen is that somebody loses some money. When this happens in the healthcare sector, we have to understand that all of our reasoning and all of our support basically has a direct effect on the life and health of the people that we are serving. So that's one specific. We have to be as errorless as possible. The reliability of the services that we provide must be as absolute as possible. So no loss of data, no loss of confidence is allowed. Health services have always been based on the premises of first, no harm, primum non nocere. Errors must be avoided, because errors, when they surface in the healthcare sector, lead to the loss of trust, and nobody will be judging which service provider to select based on the resolution of the screen that the doctor has in his office, or based on the gigabytes of RAM he has in his computer. But the service provider must be trustworthy. So we have to take into consideration some specifics of health services, and that also has an impact when we are evaluating the impact of going digital in the health service sector. Another very important thing that we have to take into consideration when we talk about digitalization and digital transformation of the health services is that in the health sector, we always meet unique and new situations. Now, if an effort of many car companies in the last 5 or 6 years has been spent on making autonomous driving cars, we have to understand that basically anyone who really wants a driver's license will be able to get one. So it is a tough job driving a car, but it can be mastered by the vast majority of today's citizens. When it comes to providing quality health services, this is not so. So it will not be so simple when it comes to introduction of digital technologies into the health services because of these specifics. Health care professionals never encounter the same situation 2 times. Always new ways and new approaches have to be found out. So it's not easy to digitalize this type of a service. Then the next extremely important specific of the health service provision is that the population we serve is extremely vulnerable. It's basically a population that covers all age groups. We are going into prenatal diagnostics based on digital services. And even post-mortem diagnoses are often performed in a digital way when it comes to the service. So we cover the whole broad range from pre-life to post-life, and we are handling not a population that is doing fine. We are basically serving a population that has an issue, otherwise they would not be coming to us. And this is not true of many other services that have gone digital, whether it's the financial or whether it's commercial services. We do have specifics in the health sector. Also, the correct reasoning and making of right decisions in the health sector often depends on information that we are unable to turn into digital code without the loss of content or context. And getting digital electronic medical records that don't specify when the numbers that are contained in these records happened, whether it was on day 1, day 3, or day 23 of the cycle of a person, then when we have this loss of context, these numbers, which have been turned digital, lose their meaning. And the last but not least specific of health service is that the introduction of new services has to be done at a reasonable pace and with backups. If we serve 3 or 4 different populations at the same time, then we cannot expect that the same type of service will benefit all of these populations. A service that might be extremely, let's say, welcomed by a young generation because it's gone digital may be extremely hurting to an older population that is not so digitally literate. So these things have to be considered. The scope and goals of the services also has seen a shift. From the WHO definition from 1984, which defined health as a state of complete physical and mental and social well-being, to today's view of being healthy as a person who is able to adapt and self-manage. And again, a lot of digital technologies have helped people to manage in conditions that 30 years ago would have been unimaginable, and we don't have to go to the example of Steve Hawking or somebody who has an insulin pump. The digital services allow people to manage situations on their own that before turned them into someone who was dependent on the service of someone else. The expert panel, after doing a thorough review of literature, has come to the conclusion that the goals of the health services, whether they are provided in a digital or a non-digital format, are basically not changed. So what we do expect from a health service is the IOM-defined goals of the service, which means we expect a service that is safe, that is effective, that is patient-centered, that is timely, efficient, equitable, and acceptable in the sense of being respectful, and that continuity of the service is assured. But when we start providing segments of our services in a digital way by using digitization and digitalization of the processes, some of these dimensions might acquire yet another meaning. Safe in the old way of definition meant no harm to the person. Safe today is also when the person becomes a series of zeros and ones, digital code, then we also expect the service to be safe in the point of view of no leaking of data to someone who shouldn't have the data available. When it comes to patient-centeredness, today, sometimes when the service is digitalized in the wrong way, it's screen-centered rather than being patient-centered. So the dimensions are the same, but indicators that we will need to measure these dimensions might need to be redefined because of the digital way of providing these services. Without problem, when it comes to digitization and digitalization of the processes, are the 6 areas that have already been addressed. Honestly speaking, when you go into a literature review, you find out that in these areas, without having the professionals forced to take up the digital environment, they take it up on their own account. Gynecologists were not taught in their school 40 years ago to use digital ultrasound imaging. But voluntarily they picked it up because it is an improvement of the services that they provide. So in these areas, there is a voluntary uptake by the professionals, and especially in this area also by the lay population. And the only thing that has to be done is to support the lay and the professional community in using these opportunities to the best possible extent. Where we still see areas of possible improvement is on the level of interaction between the digital and non-digital, and between a technology and a whole system. The clinical microsystem is a unit that is becoming extremely complicated today because it's the patient themselves, it is the professionals, it's technicians, it's people that are doing information and communication technologies, and it's lab people that have to collaborate in the provision of the system. And sharing of data in these areas is becoming complicated, and without the intervention on the macro level, the codes that are being shared might differ, resulting in miscommunication of a larger degree, because even though we called the society Information Society way back in 1960, one of the Kennedy brothers also used the term Disinformation Society. If we have an environment that allows us sharing information, we also have an environment where sharing disinformation is as easy as the sharing of information. And obviously this does impact the way how health services are provided. We don't have to go too far. One of the biggest hoax that has been shared is the vaccination hoax. And we see the impact, and it has been discussed in the last expert opinion voiced here not so long ago. So the effects of the sharing of information and sharing of inappropriate information must be noticed. And it's not just about changing a system as such and introducing digital technologies, but it's also about knowledge, education, and culture that have to go hand in hand with the technology advances. And again, this has to be monitored. The data flow, again, providing everything to everyone doesn't have a meaning. When it comes to evaluation, we must assure that we evaluate in systems that the right data goes to the professional community when it comes to medical community, the right data goes to the professional community when it comes to managerial communities, and the right data goes to public. And that again is not played to the major extent. We see a definite shift in care into these areas, and that is a direct impact of the digital options that we have today at our disposition. When we talk about evaluating the impact of digitalization in healthcare sector, we have to also set up systems that will be fit for future use. If we just set up systems that measure what is happening today, we may be, because of the unpredictability where the interaction between health and digital will go, may end up when having systems that are unable to measure what is actually happening in the healthcare system. Evaluation and monitoring requires relevant data. One advantage of the digital environment is that it can produce a lot of data. We are talking today about the big data issue. Big data is wonderful, but it has to be used appropriately. And the data should be gathered, but it should be gathered on a purpose and should be fit to address the questions that we want to address. And also, because of a quick possibility of editing digital code, we must be aware that digital data if it is not handled by professionals, may be gamed very easily with very much undesirable effects. There are not too many frameworks for evaluating what is happening in the health service provision under the effect of going digital, but some frameworks are emerging. 2016, WHO has spent quite some time analyzing the situation. They have devised some frameworks which are cited in this opinion. We acknowledge the categorization that has been used by the WHO. They have categorized the digital services into intervention for clients, healthcare providers, health systems and resource managers, and for data services. And on the decision-making level, WHO acknowledges centralized and decentralized way of evaluation. There are some age technology assessment-based evaluations of what is going on with the digital transformation. A minimal HTA-inspired framework has been piloted in Europe in the Norwegian countries, and it seems to provide a reasonable framework for evaluating what is going on with this system change in healthcare. The framework is based on addressing the feasibility, usability, efficacy, effectiveness, and implementation research, and it does make a lot of sense. It addresses the developmental phases, it addresses evaluation and assessment of pilots and early use, and it also considers evaluation of routine use. Essentially, the methods are the same methods that were used when we try to assess service provision in healthcare without considering the digital impact. So all quality measures and all ways of assessing that have been institutionalized in the effort to obtain quality and safety health services can be used also for assessment and evaluation of the impact of the digitalization. It is interesting when it comes to trying to find out as generic as possible recommendations for prioritizing what to evaluate and what not. Because obviously not everything that happens in the healthcare sector can be assessed, can be evaluated, can be monitored, and can be used for improvement. When we talk about prioritizing, the most generic, what we were able to suggest is to consider what type of technology is used. When the technology, the digital technology, is dominantly based on human physical capabilities and automatic algorithms that can be implemented, then the effects are usually foreseeable. If you can run the pharmacy and dispensing and checking of expiration of drugs in the background, and you don't have to have this done by the professionals, obviously this helps the situation and is one of the examples of well-performed digital technology shift in healthcare provision. If, again, the digitalization addresses the augmentation of human senses, so digital imaging techniques, obviously introduction will be easy, monitoring will be easy, but when it comes to technologies that are supposed to help with the intellectual capabilities of all the stakeholders in the process, doesn't necessarily mean just the medical professionals, but also we are trying to provide today digital online services for the lay community, then the side effects of such provision, because of disinformation, because of possibilities of manipulation, because of possibilities of not having the right context, then we have to consider strict evaluation and monitoring of the introduction of such digitalization processes into healthcare, because there may be undesirable side effects. The expert panel tried to produce a sample checklist for the evaluation of digital services based on a plethora of gray and evidence-based literature. Why gray literature? Because failures are usually not reported in the most impacted journals, and the failures have to be monitored as much as the benefits. Otherwise, we might see a bias that anything that has been done digitally in the health service is beneficial. This is not so. So the expert panel tried to put emphasis on creating conditions, on evaluating whether the introduction of the digital technologies was on a voluntary basis, and we do advise the construction of a European repository of the ways of evaluating the digital services, because we have not found any place where there is a collated effort of showing what possibilities of monitoring the health service provision we have today. In principle, the expert panel feels that where the digital and non-digital can be benchmarked, it should be done in order to show whether the introduction of digitalization has been beneficial. The expert panel finds it appropriate when it comes to monitoring to find frameworks where a combination of evaluation would be used. So, multi-dimensional view of the impact of digitalization into the health services should be considered, and the evaluation should cover both the intended, the positive outcomes, as well as the unintended or unexpected outcomes. And the reason for evaluation, obviously, is not just to produce reports, but to feed the evaluation data into the plan, do, check, and act cycle. So essentially, use the data that is produced by the digital systems to modify the behavior and optimize the behavior of the systems. When we try to answer the mandate, if there are existing methods best tailored for assessing the value, then we have to state that at this point, we don't have tailored methods for assessing the digital impact on health services. And that's because it's a highly difficult task, and that's why a repository of approaches would be beneficial. There is some improvement due to the effort of the European Commission in this area, but it needs to be followed. We have used the digital also in agriculture. We have today basically digital farming production. We have turned farming into a factory, and it's a GPS-driven tractor dispensing fertilizers in the field. We have taken the factory to the field, but the undesirable effects of polluting the water, which are coming out at a later time. And when we try to do the same type of a shift in health service provision, we should consider these issues before we find the side effects that we did not expect. The second question was if there is a need for the modification of existing method that we have for the assessment. No, basically all the quality methods can be used, but because of the shift in the dimensions, what was considered as safety, what is considered as safety, what was considered as patient-centeredness, and what may be lacking when we go digital, we have to modify what we have done for quality monitoring in order to be fit for use for the digital services as such. The data that we have available are the big data, but they have to be handled efficiently. In a sense, we are driving healthcare services into a situation where unimaginable things are possible. Now, somebody can be omnipotent only if that person has all knowledge. The difference between God and us is God has a bigger screen. What we have done digitally is we have big screens today, but we don't have the time to see the film. The effort of doing medicine right today is basically understanding the life story of a person. That life story is going corrupt. That's why that person needs a health service. And the professionals should be able to read as much from the life story of that person, and that's based on the data that is stored in cloud from smart refrigerator to smart armband. So we basically have the whole life story. But we are still not very efficient in making a trailer from all the data that is in the cloud so that in a short span of time, the decision making will be better. So this is what has to be achieved, and this shift has to be monitored. The impacts of digitalization of health services that should be monitored systematically is, are we improving the situation of the people that are receiving the service, which means are we helping these people with better decisions so that they can manage better their life conditions based on the data that they have provided the health-serving community. And the interventions that we need to evaluate should focus on the most relevant outcomes, and the most relevant outcomes are really the prospective, predictive, personalized, and goals-oriented care. So we should reshift from treating diseases and diagnosing diseases into these areas, and the digitalization does help us in this respect. The impact should be considered with regards to health outcomes, and there are some beyond the health sector issues that have to be taken into consideration when we go about evaluating the impact. And that is, have we empowered the patient? Have we empowered shared decision making? And are we attaining the goal-oriented care? Are we supporting the governments enough so that they have sufficient knowledge what to do digitally and which areas are not so prone to be helped by the digital servicing? Are we doing it right in respect to patient privacy rights and data protection principles? So not data to everyone, but data to responsible, accountable people that are using the data in order to make the best possible decisions. And that also means limiting the data streams to the different communities. Are we taking into consideration the role of professionals, and are we steering the development of the digital services, or are we letting the market to take care of this on its own? And we have to be aware that if we lose the trust of the community, then it takes a lot of effort to rebuild the trust. It's this 1 to 5. You lose the trust, takes you 5 times as much effort to regain the trust. So possibly during the process of digitalizing the services, let's not lose the trust of the communities that we are serving. The expert panel has summed up 10 major recommendations when it comes to monitoring and evaluation of the digital transformation of health services, and that is focus on the development of a strategy for digital transformation, developing a coherent framework for monitoring and evaluation, possibly put up in the European repository, which is the 9th recommendation. There should be investment into robust monitoring and evaluation methodologies based on validated measures, possibly on measures that are not being gamed by people but produced by the digital systems themselves. There should be investment in systematic evaluation of procedures, in evidence-informed policy measures. Decentralized decision-making should be encouraged, but decentralized decision-making also depends on centralized setting of the codes and protocols of transferring information first. There should be major investment into aligning literacy with technology development. It is not enough to develop technologies without having knowledgeable people voluntarily change their behavior in order to achieve a synergy of appropriate use of the technology. Don't use the spade for a farm animal to dig in your garden. Change the process of digging with spade into using the plow. Don't give a professional a computer without supporting him in how to use the digital services available. Don't let the lay people find out for themselves what are the best channels of information. We need to invest in aligning the literacy with the technology development. We have to aid the development of environments that want to adopt these changes rather than forcing people to do things. And we have to be progressive when it comes to introduction of digitalization into healthcare, but we must be cautious because some of the results, because the virtual things are non-evident, we have to be cautious and not introduce things just because they can be introduced. The expert panel feels that the terminology rather than digital transformation should be digital aided health service transformation, and we see the digitally aided health service transformation as a way of helping ordinary people to achieve extraordinary results. If, on the other hand, we don't support the literacy in people, we often see the opposite effect, that when we give the technology to the people without supporting them in changing their behavior and acquiring new instincts and reflexes, we actually have extremely capable people slowing down in their progress. Be progressive, but with caution. We can also have totally dehumanized medicine if we turn every person into a set of digital code, and if we take the perspective of professionals of helping people to people, of helping professionals in editing the digital code. When I, as a doctor, had to measure the blood pressure of a patient, I would also observe the patient, and I would get a lot of information in a non-digital format, which helped me to propose decisions. Today, when this is done digitally, a lot of this doesn't happen. Just the numbers jump into the appropriate electronic medical records, but the effect of improving the service has not been observed. And it is the conviction of the expert panel that we should introduce appropriate evaluation and measurement in order not to end up in a situation where we finally have more problems than we had before the introduction of the digital services into the healthcare sectors. I would like to thank all of you for listening to all of this, and we are very much looking forward for you. And we know that you had limited time to have a look at the document, but I'm sure that many of you have found some ways that we could improve that document, and we are looking forward to hearing them from you now. By this, I give word back to you.
Thank you very much, Alice, for this introduction. You took us through a comprehensive walk through the last 30 years, because that's the time span we are talking about, and where all these changes came, and you put them into the broader framework as we tried to do together with the panel in this report, looking to what extent the digital opportunity can serve the purposes of improving the health of people individuals and populations. So this is food for thought. The invitation is that you take the microphone will circulate, you present yourself, you give your background, and you put your questions clearly, and then we will firstly try to make the inventory of that, and when needed, give some clarifications and explanation. And so also Lasse and Werner are here together with ICE to bring in the information needed. So the floor is yours. Yes, please. Okay. So stand up, present yourself, and give your background, and speak loudly into the microphone when it's switched on. Yeah, you have always, with technological transitions, you have always some problems, but they are solved now. Go ahead, please.
Thank you for the opportunity for the input and the great document. I'm Ioana Psaki. I'm representing the European Alliance for Vision Research and Ophthalmology, effectively is the ophthalmology community of Europe. We did look at your document despite the very brief time that we had to, and we applaud an awful lot of the points. What we are worried about and our concern is that you're talking about the future dimensions, and cross-border care, the European reference networks, offer a new dimension in the digital transformation in terms of interoperability. And the indicators that you're providing for the impact, they're not accounting for the interoperability issues. So if you want, particularly for the upscaling of the services, this is really critical. And because cross-border care is a special decentralization of decisions, centralization, and more, and that's not, the indicators don't cover. The other issue that we have, am I allowed to comment or?
Go ahead.
That the impact, particularly for the patient, has to be across the entire pathway. And the phrasing of concentrated evaluation of the service may actually not, may create the wrong perception. It would be nice to strengthen that the evaluation must be on the service in relation to the goals, and that's patient-centric and across the entire pathway of the patient, not just, let's see how the electronic records can make it faster to communicate. And the problem we've encountered with some other work we're doing with the European Commission is that the impact on patient needs utility measures. And utility is quality of life and well-being. Not many, and because you're talking about the decentralized decisions and supports to them, not many individual settings like hospitals have actually got those measures in place. One hospital in Finland, which is doing great work, is actually stuck that they cannot use the MAFEIP tool, which the Commission has produced, because the MAFEIP tool wants utility measures, which they've only introduced to the hospital 2 years ago. And we cannot show the very long-term effect that the intervention did. And the problem with the measures of these, they will actually have an impact on the longitudinal evaluation of the digital surveys. So, for example, the issues that they may encounter now, the same hospital in Finland, that's the Price Eye Center, is also measuring impact of the IT, electronic records and whatever, and they're coming up with an awful lot of adverse, not adverse effects, but sort of like negative effects. Patients are staying in the wrong waiting area for 2 years now, and they've only realized it. It takes a long time to actually open all the documents to find what they need. But these may be related to the digital maturity of the intervention rather than on the digital service. And I think the concept on the WHO, which are measuring the maturity of the intervention, is very important. That maybe could be highlighted, that the evaluation must be measured digital maturity over time, and that will actually be a more fair assessment for the impact.
Thank you very much. I try to summarize. Your worries and concerns are about how to integrate the cross-border care. For your information, of course, you all know that we had recently a presentation on the European reference networks, and that actually on our website is a new opinion on that one. You mentioned the importance of the interoperability indicator that, to your assessment, is not sufficiently come into the spot in this document. Then secondly, you want us to look at the patient from a longitudinal perspective. The pathway is important and the service in relation to goals. Thirdly, you mentioned the importance of utility measures. I think the report also names it as one of the ways to go. Certainly also in longitudinal approaches. And you ask our attention for the digital maturity of interventions as an important concept. Other reflections from the panel, we don't have to debate them, but the question is, this intervention, to what extent it can enrich our document, or it is already covered? I don't know, Werner, maybe you can reflect on some points and then the others can jump in.
Yes, well, first of all, thanks. Let me address all three. So the interoperability is an important issue. I think we stress it already. You place it in an even more complex environment, namely cross-border care, which you could see as let's say, taking the decentralized decision-making to a next level, namely seeing the different countries as decentralized and therefore making it very difficult to cooperate, or potentially difficult to cooperate. I think that is a fair point to make, and I don't think we have placed it in that context as yet in the current report, and I think it adds value because I agree that specifically in certain circumstances, and ERN networks could be one of the examples, but we also know the border regions, of course, where cooperation is truly very important. Things like this could in fact, at the end of the day, potentially even hurt patients if we don't correctly deal with this. The second issue was the network. I think we stressed that. I will, together with all the colleagues, of course, reread whether we do that sufficiently, but we fully agree, of course, that it's about networks, that it's about patient pathways. And if there's one change in a pathway, you should look at the effects on the total pathway, not only isolated to that only change. So I think it is in the frameworks and in the thoughts, at least, behind the current report. Again, we will look into whether or not it's sufficiently clear. But I fully agree, and I think the full panel does, that, of course, at the end of the day, it's about the total effect that you have on a pathway. Finally, utility measures. As a health economist, I need to disclose my own background, of course, as well. I am pretty much fond of utility measures, although I don't think they are the true answer to all situations. There could be situations in which you would prefer patient satisfaction or other types of clinical measures. But I do agree that there's a difference in terms of the availability of utility measures at different levels of our healthcare systems. To my own dismay, I may add as well. And it might be good because we talk a lot about the alignment between the different levels in our healthcare systems. And of course, even if you would have alignment in terms of the goals that we pursue at the different levels of our healthcare system, but you don't have similar instruments to see whether or not you're on the right track, you could still have differences at the end of the day that might be unwarranted. So I'll look into that one as well. I think they're all three valuable points. Yeah.
Yes, Alice, you can take over and also address a little bit the issue about the digital maturity concept.
I think the important observation is the interoperability. We have ICD-9, ICD-10 coding, and that's the loss of context that I tried to address in the presentation. If with the electronic medical record it doesn't come out which coding it was, then let's say essential hypertension in ICD-9 is 401 and in ICD-10 is I-10. So these confusions will happen unless we take care of assuring that we are using a common language. The whole impact of the digital environment is that for the first time in human history, we decided to use transmission code protocol, internet protocol, TCP/IP. And for the first time, we have an international code that allows us to collaborate. If we confuse the code, then we can expect the same effect that we saw with the Tower of Babel story. And these indicators have to be taken care of, and that comes to the digital maturity. A mature person is the one who voluntarily adapts a code of conduct. So if everyone uses their own code, we have complete anarchy, but it will be a digital one. And if we decide on common languages, then possibly we can find the same voice and we can start collaborating in a much more efficient way. So these indicators are important, and they should be a part of the repository in the European repository. And they should be, these are the basic cornerstones. If we don't speak a common language, I mean, English is not my mother tongue, neither it's the mother tongue of many of you, but we decided on a common code, and it reasonably has the same meaning when we turn into English. But we have to do this and we've done it in robotics, and in those 6 areas that we have addressed in robotics, in digital imaging, DICOM format. So we have to work on the interoperability, and that is by setting a common language.
Yes, please.
Just one addition on the digital maturity that I forgot to mention. It is a puzzling one as well, right? Because at a certain stage, especially if we talk, so in the report we distinguish a bit between centralized decision making that you need to do at a certain stage. Then the maturity of a new intervention, of course, is crucial. If it's very early on, you're not exactly sure as how it would turn out, but if you wait too long, you might have missed the boat entirely. So it's also about the optimal timing of your decision and your decision framework, in which you need to take into account the maturity of an intervention, but it can also pose a problem as to sometimes you just cannot wait any longer. There are things like learning effects, even more difficult so in the sense that some of these learning effects might be different in different environments. So whereas we like to look, of course, at those things that are pretty much stable across different settings where we use the thing, like in pharmaceuticals sometimes the case. For these types of interventions, it might well be that the environment changes the way in which the digital thing works. And that means that it's not only about maturity, but also the places in which it is used and the interaction with that environment, which makes this an incredibly complex issue. But it's absolutely the case that maturity is a crucial thing. That's why we also note the WHO report so strongly in this report as well.
Lasse, do you want to add, please?
Yes, concerning the digital maturity, I would still like to emphasize that I think the opinion of the panel was that we don't want to have any other criteria for evaluation of the health systems that are already established. So it's a little bit difficult to evaluate digital maturity without really looking the overall goals of the health system. There are systems for individual healthcare units where you can assess the maturity of the hospital, for example, on using digital services. But if you look at the healthcare system as a whole, I think we have to stick to the general criteria as we have indicated in the report. And then I would strongly support that perhaps we should emphasize the interoperability issue more in the evaluation. That's there, but I think that should be stated loud and clearly that that's an important issue, because it's a true problem if we are trying to transform the health system, that the interoperability issues are, especially in the decentralized decision making, they are not looked after.
And finally, my background as a family physician, primary care worker, I think that Alex said we need to look carefully at the coding system. And of course, you can look at the medical issues, and then you have ICD-9, ICD-10, but you can have a broader look. Today, care is interprofessional. And if you go for goal-oriented care, means care that looks at the goals of people. The goals of people very often are formulated in terms of functioning. So then you will need, for instance, international classification of functioning if you work interprofessionally. So we also have to prepare the future and to enable that this new kind of approach in the practice can also be translated in the way we use the digital aspect of our service delivery. So thanks for this question. This was really helping us a lot. So floor is open for other questions. Yes, please. Present yourself and speak loudly. The microphone is arriving.
Hi, good morning. My name is Jan de Bely. I'm a pharmacist from Belgium and working for the Pharmaceutical Group of the European Union, the PGU, which is the association representing community pharmacists across Europe. So, as a representative of the pharmacists and so a healthcare part of healthcare professionals, I'd like to congratulate you taking into account indeed the roles of the healthcare professionals and also certain important aspects there. I think co-creation is one that has been mentioned, taking into account also the experiences of healthcare professionals with these products and digital services to ensure that they're one fit for practice, but also that we don't dehumanize health, as it was said so nicely. We also very much embrace the focus on education and training for healthcare professionals when it comes to digital services and also when it comes to saving, improving, increasing the efficiency in the work. I think the example has been mentioned, for instance, in the pharmacy with dispensing, making sure that logistic procedures or administrative procedures can save time to have more time with patients. I think these type of recommendations we also very much embrace. When it comes to something that could be have a bit more of a focus in this document, could be more on the continuity of care. And here, for me, it's not really on cross-border, because it's also, of course, very important that is we just discussed, but also within the national system. And I think Professor de Masnier just mentioned it already, exactly to come towards a more integrated care model. I think their electronic or digital services have a very high potential to increase the collaboration, make this more efficient, communication between healthcare professionals, and sharing of relevant information that's needed in every type of care setting. So this is something that we saw that was not very much present yet, so we would welcome a bit more emphasis on this. Thank you.
Thank you very much. I think that's a clear statement, and we will certainly take this on board. Very correctly you say, when it's about 24/7 continuity, especially when it comes to informational continuity, digital services, of course, may make a big difference. Yes, please, Werner.
Yeah, perhaps just to indicate and stress that in some ways what you're describing is the one minus what we described. What, of course, we focused on to some extent are the problems with achieving exactly this, the continuity of care, and it's one of the things that is already also listed as an element of quality. But if you want to achieve it, you both run into the problems of interoperability again, you run into the problems of information sharing, you run into potential risks in terms of who gets to see that information, when and why. And to some extent, we might have focused a bit more on that particular element, not to discard in any sense the fact that, of course, the ultimate goal is setting aside all those problems and hopefully overcoming those problems to get to a better continuity of care.
Lasse, please.
Yeah, in the final recommendation we said we progressive with caution, and I would raise some of the caution issues just in relation to the continuity of care, because system resilience is critical, because if people start to rely on the services that are available 24/7 for remote areas and so on, it's of huge importance that then there is no interference and that there is a spare system that can work if the systems break down. So that's an issue. On the other issue and problem is the equity issue. So if you put these systems available for the whole population, you start to have groups like visually impaired who are unable to utilize the digital services if there is not specific equipment. And then there is this conflict between the privacy issues and sharing of the information that is very difficult to solve. Looking, for example, the mental disorders where you really need the integrated care if you want to have good efficacy for the treatment, but the issues are very sensitive for the patient and could be socially problematic if the information is shared with a large group of people, and these things have to be really be balanced, and we have to be cautious and test and look the unintended effects that these types of systems may have for from the societal aspects.
Yeah, I think it was a very important remark what you had. Essentially, if we do services digitally, then a human needs checkpoints. Come to a person and ask. And there are many formats how this can be done, but obviously the digital transformation requests us to shift just from the doctor doing these issues. Because if somebody gets a telemedicine support, then at a certain time he arrives at a point of not knowing whether he is doing those things right. And he needs a professional, not for the facts, but for giving weight to the facts. And this can be done in a much more orchestrated way, and finding indicators for this collaboration that goes across all the different providers will again be challenging, and I think that the expert panel would like to see more of an effort of the Commission in helping in constructing these indicators and following this line of thinking.
Okay. Thank you for the intervention. Please take the floor. Stand up and speak loudly and present yourself.
Yes, good morning. My name is Dorota Sienkiewicz. I work for the EuroHealthNet, which is a European partnership of organizations from across Europe working on health equity, health promotion, disease prevention. So in a way, strictly speaking, we do not represent core health professionals, but public health authorities, I would say, also at a regional and local level. Therefore, my question is perhaps not very seen as a kind of expert from the healthcare services perspective. I've attempted to read the 100-page report. I'm not there yet, but what I read so far and what I've heard this morning is very interesting, and I've heard a lot of really good stuff about putting an emphasis to equity dimension, maybe trying to shift the focus from curative care a little bit more towards the preventive care. So the continuity of care that was mentioned here as well is something that we definitely very much support, and also kind of trying to see how it fits within the community-based delivery of care. So that's something that we really like, and also the one of the 10 recommendations was to not to introduce, be careful with introducing services that are delivered in a digital way without having any backup, because what we don't want is to have too tired system of delivery of care where digital services work for a kind of certain populations, while we do not continue improving the healthcare services for underprivileged groups in our society. So that's something that we really want to kind of stress in this regard. What I kind of missed a little bit, maybe I haven't read it yet, is how the digital transformation can support the role of health services, health systems, and health professionals in addressing the so that the health inequalities that we see are still persistent and in some member states growing, by addressing social determinants of health. So what's the role of this in this regard? And then you mentioned that the real-world data is really difficult to get. So my question is, what kind of what kind of evidence would need to be sought after, investigated by not only the core health services, but also by public health community across Europe, and also maybe, as I mentioned, health is not only created by health systems. It's also the public health community that participates, co-creates the health outcomes. Therefore, also perhaps maybe stressing a little bit more the capacity building of this community and the public authorities that would then have to also deal and contribute to appropriate design, implementation, evaluation, monitoring of the digital transformation of health services across Europe. I think that's it. Thank you.
Thank you very much. You addressed the important issue: to what extent can health inequities, social determinants of health, be addressed, and how can digital services help us to do that better? You asked some question about the public health and how this relates to this presentation. The issue of real-world data and the capacity building, so that, well, the outcome in terms of health equality improves. Yes, was that more or less the point you made? So please, who is going to start? Yes, Werner, you can start. And then
all right, so let me start by saying that we took a broad perspective on health services, so that we tried to include the whole range, including the things that you emphasized. Second point is, yes, we have emphasized equity as well. I think we have done so consistently throughout the reports that we have made as a panel, because, well, I know in my simple world, sometimes I only talk of two simple goals that a healthcare system has. One is efficiency, to produce as much health as possible, and the second one is equity, namely that health should be fairly distributed over groups of people. I think in the report there is quite some attention to equity, including, and I think that is important to stress, that digitalization can solve problems in terms of equity. For instance, increasing the access to healthcare in rural areas or remote areas by new connections, telemedicine, and so on. But it can also create new types of inequities. And in that context, it might be good to refer to terminology, whereas in the old days there could have been an inequity between the haves and the have-nots. And nowadays, sometimes you see a new division in terms of the cans and the cannots. Those people who can access, who can work with digital environments, who can work in digital environments, who understand the information that is provided to them through all these types of processes, because we tend to think that all people are very happy if they get a lot of information. Not all people do. Some people really like others to make those types of decisions. We need to be careful as to overstating and again expecting effects of providing information, of doing things that in real life might not occur. So yes, we can solve inequities through this. We can also create new inequities, and we need to be as sensitive to the new ones as we were to the old ones. So I think that is the main line of the document. In terms of prevention, self-management, community-based, I think a lot of the general tendencies that digitalization has in it is to move away care from hospitals, from fixed environments, from fixed places, to all over the place, including home, making people themselves much more in control of how they manage their own diseases, but also how they manage their own health promotion and self-management. Some of the things that you said, so I think we take a very broad view, but I would like to also refer back a bit to the mandate. The mandate that we have was, how would you evaluate such a thing? So what we try to do is to emphasize, including those things that you mentioned, so the important things that should be included in any evaluation of digital health services. We did not write a report to indicate that we felt that digital services would be most appropriate in certain contexts, or they would be most attributing to, for instance, equity solutions. The only thing that we try to do, and as you gather by now, given that we already took 100 pages to write it, that is not an easy thing in itself. So what we try to do is to emphasize, if you are dealing with evaluating these types of services, you need to take that broad look. You need to look at a total pathway. You need to look at health promotion. And you cannot just look at what type of health outcomes there are, but you also need to look at, if you serve new people, are you also leaving other people behind that were served before? And that's why we also, for instance, make the distinction between complementary health services, so that just add on to the things that we already had, or substitutes that simply substitute the thing that you had before. And especially in the latter case, of course, there can be a danger of people who were happy with the old service but are now left, well, potentially even unattended to in the new service. So I think we to be as balanced as possible, again, within the mandate that we had, and that especially as to how to evaluate, not so much as to where we thought that the digitalization would lead us to, or where it would have the biggest impact.
Yes, please add to that.
No, actually, I think Werner covered the topic quite well. I think we tried to take into consideration the equity issues consistently in the report, and really pointing out both the benefits and the problems that we might have with the digital solutions.
I just wanted to add one reflection, because I come just back from the WHO conference on primary healthcare in Astana, and it was emphasized very strongly there that the integration of public health and primary care is absolutely a step forward and the next step to do. And it is obvious that we have to shift from an individual diagnosis, where digital, of course, services can help a lot, to the community diagnosis, where public health is dealing with. And I think that, of course, the digital transition enables us to do that in a quite consistent way. And that could be a new perspective for the future that then also could be part of the assessment. And that certainly will bring together the concerns of public health with those of primary care. Yes, other questions, reflections, remarks? Please, in the back. Present yourself.
Thank you. I'm Tobias Etter from Roche Diabetes Care, and from an industry perspective, we as a medical device manufacturer, we definitely are involved into health services as well, and we have the discussion together with MedTech Europe about HTAs in combination with medical devices, and we are definitely open for working together, transparent and voluntary, with HTA bodies, and we come to the conclusion that it has to be in the end a fit-for-purpose thing, this HTA, because as we all know, HTAs were originally made for pharmaceutical products, for medications, and so we have to find an adaptation of this. Another thing is, I like this interoperability thing, because when you think of chronic diseases, you not only, I appreciate that very much that you said we have to find a common language for it, but we also have to find a common basis for data, relevant data for all stakeholders. And this makes it much easier that the specialist can, for example, decide on a therapy, and then the general practitioner can continue on this, because as you know, we have a lack of specialists in all countries in the European Union, and the general practitioners have to take over the opportunity and the responsibility to continue the therapy. And I think this is an important point, with the patient in the center. And the patient is the owner of the data, and of course he has to decide what data he has to present or open for the physicians, and he has to be aware that there is not necessarily a risk when he opens the data for the physician, that there is more a benefit for him. And I like also the point that you said we should have progress with cautiousness. And well, first when I heard it, I thought it was some kind of distracting. It's progress and caution. Well, you have to risk a bit to be innovative, to go forward, but without harming people or without taking people at risk. And so we, for example, have an EU-funded project that will start next year, where we deliver the risks on many shoulders, that we work together with a municipality which reimburses a certain service. That means that we provide test strips for patients, that we provide a certain software, an app, and so on, and that we say, okay, we take some certain risk too, and we say, okay, we can deliver a basic therapy, and when the outcome improves, we get a benefit. When the outcome decreases, we get a malus, and that means less money. And so this is a very, very good advantage for the payer, for example, because he knows exactly what to pay for 1 year for one patient. The patient in the center, he has the benefit that everyone is willing to increase the outcome. The doctors are willing to increase the outcome as well, and that it is not a one-size-fits-all solution, and it is not a per capita solution, that is really the patient in the center with an increased outcome. And yeah, those were my 3 comments.
Thank you very much. Alice, please.
I would like to comment on what you said, and it gives me an idea of some of the indicators that we have not put into this study. The level of collaboration between commerce, professionals, communities themselves. I'm not aware of any indicators that cover this area, but they would definitely be beneficial. It comes into this concept of shared care. Different people are, and different organizations and different organisms or corporations, it's always about a body in principle, have different opportunities to collaborate if we find the common language. But we should think about an indicator that could show us that it goes from traditional ways of collaborating into these, let's say, more efficient and modern ways of collaborating on the level that you have addressed, and we'll try to see if we can find something to put into the paper on that.
Yeah, I know well the idea of the common base for information, but I just want to point out a few of the challenges. I have the background of working in the biggest hospital in Finland for the past 20 years, and before that in pharma industry for 10 years. And so when we're looking at the clinical trial data, whether that's for the pharmaceuticals or medical devices, it's usually at least triple checked. So first you have the study monitor, then you have the data manager, then you have the authorities to look at the data, and you are pretty sure that it's put correctly to the database when you have it in the end of the day. In the clinical setting, we always have the difficulty that the patients change. When I used to teach patients on medical therapies, I used an example of obese 70-year smoking lady that comes to a hospital with shortness of the breath. So it might be just that she has COPD, or she had a high heart failure, or could be just that she has a poor physical capability. But the point is that if the doctor puts at the patient records that the reason is COPD, it might still be heart failure, so we don't really know what is the basis there. So you have to be able to change the database, and that makes it so very, very difficult to create reliable databases that you could both use in the development of devices and in the clinical setting where the situations change all the time. So it's very difficult. The other issue there is that very often or quite often actually the patients and doctors don't disagree, especially that's for the psychiatric disorders, but nowadays we have a vivid social media which creates all type of symptoms and diseases, and even though doctors think that you might have this disease, the patients find another, and it's constant discussion with what is that, and patients want to add to the patient records that this was the opinion of this and that guru, or I read from this. And what is then the basis of the data, whether it's the patient's opinion or whether it's the physician's objective assessment of the patient. So it's very difficult to create this type of database that would be universal, and actually in our hospital, and that is our policy of our hospital, we try to be objective and rely on the medical profession of creating the data, even though we know that it's not always that valid, but that's best what we have. But as just wanted to show out how problematic that is, and I think due to the immense task that we have with the digital transformation issues, we didn't actually go into the details with the data basis, and I think that could be a topic for a new mandate for the expert panel as such.
Yes. Alice, you want to give a reflection on this one?
Very quick one. For some reason, people have noticed that in many of the networks, some of the boxes are called servers. And people don't have an understanding that, as opposed to 40 years ago where only the rich had servants, even the poor today can have servants on the servers. Essentially, it means putting the data in a cloud and then having a server make the trailer from the data, which means working on algorithms to select action frames for the whole uploaded data films, so that it allows people to make better decisions. And this is where we need to collaborate, and this is what we need to find indicators to nudge into that way of working. It's not just putting big data somewhere, but having a server who is able to work with those data and feed that data back to people that need the data for making the right decisions. And it's not constructing databases, but it's being able to pick the right data from the clouds at this point.
Okay, thanks for the comments and questions. Just a quick response from me as well. First of all, on HTA being fit for purpose, fully agree. I think, like in many cases, it is often dangerous if we forget what we designed something for to begin with. I think HTA was based on the whole idea that we needed to have a broad look at new health technologies and to assess their cost and benefits in a very broad sense. That is what this report also tries to do, to highlight some of the peculiar aspects of digital health services in that context, and to argue that that should be fit for purpose. I think there's already quite some work underway in that sense, especially for medical devices. I just named the Pecunia and also the COMED projects that are now ongoing, also European Union funded. But I think we need a lot more, because it's about outcomes, it is about the maturity, learning effects. There's a lot of things going on in medical devices that we need to have a very close look on, and not all the methods that we need for that are already in place. So I think we need to work more on that, and I think the report already indicates that. The other thing, just to say a few words on things like risk sharing. So, of course, this is an important issue. It goes along very well with value-based healthcare and all these things. And I think we are moving to new models. I think the way in which we move to those new models is not completely clear. I think we all talk about value-based healthcare, but it means many different things to many different people. And making it work in practice often is quite difficult. So what type of outcome measures are you using? How will you collect the data? How will you make the arrangements, also the financial arrangements? That is not very easy, but I think it's important that we move in that direction, and there's also that we progress with caution to new roads and new eras. one of the things that is also important to mention, and it's also important to mention because it's in the report, is that of course some of these new elements also bring about new information. And that information to some extent is also something that is power in itself, which can be used commercially, which can be used publicly. We have big data, but we also have private data. So some of the things that you see going on now, and I'm not talking about this particular example, but is a shift towards less product-oriented and more information-oriented, which also gives new business models, which is a positive thing, but also gives new questions as to how, as a society, we deal with those new types of business models, and what type of power is associated with having particular types of knowledge. So in that sense, I think it's really important to experiment, but again there, to have a very balanced view on what it exactly means for both sides of the table to encounter in these new types of interactions. I think we're moving in that direction, but I think both sides of the table at this point still have questions as to what that will look like in, let's say, 10 years' time.
And to give you an advertorial, one of our next opinions will be on value-based healthcare. So keep you informed. Okay, other questions? Yes, please.
Thank you. My name is Daniela Negri, and I work for Weber Shandwick, which is a public affairs agency based in Brussels. So, of course, also welcoming your opinion, and thank you for putting the emphasis on the importance of new evaluation frameworks in order to assess the impact of new health interventions, also supported by ICT solutions. So, I personally think that it's very important that your opinion is also linked to what the Commission considers as best practice. You put the emphasis, on the importance of decentralizing, of pilot interventions, and you also mentioned this repository. So we conducted a couple of years ago a study which actually looked at 16 best practices that were labeled, from the Commission as best practices in the area of integrated care. And because we were expecting, to see that actually these integrated care interventions, would be linked to increased health outcomes. However, we couldn't actually draw this conclusion because what we discovered was that only 2 out of the 16 best practices had measurement and evaluation frameworks in place and could actually show, that their interventions, could link and could be associated, with increased health outcomes. So the conclusion of our paper in the end was that, of course, there were clear factors that we could say, were improved. For instance, healthcare professional satisfaction and also patient satisfaction. However, we couldn't actually, prove that. And we could only say that 2 out of the 16, also had quantifiable data supporting that actually these interventions, led to improved health outcomes. So your opinion, of course, it's crucial, comes at the right time, also before the elections, and hoping that this would also lead to, to put this on the agenda of the future European leadership. But I personally think that it's essential that what is labeled as best practice and is actually, set as a best practice for other, areas, can also bring, data to corroborate that they can make a difference, and they should be, adapted to other local contexts. Thank you.
I think your intervention is a perfect trailer to raise the attention for the issues that are dealt with in this opinion. Thank you for that. Other people that want to give some comments? Bernard.
Yeah, just I fully agree. I think this report signals that I think it signals 2 things. You cannot evaluate everything. And I don't think we need to evaluate everything. So we need to think about when do we want to actually evaluate stuff and when do we just leave it up to the market or the healthcare professionals or whatever entity is involved in getting this into the market or into the healthcare system. But there are things that we do want to evaluate, and I think by setting, and it was in the recommendations, by setting clear rules and regulations for when you want this evaluation to be done. There is a strange discrepancy in many healthcare systems as to what type of health services we evaluate and which we do not. I think to some extent that has to do with very practical things. It also has to do with the policy environment. There are environments in which we can have a third party be responsible to give us the evidence, like in the pharmaceutical industry, we just force them to give us the evidence. There are also environments in which that is much more difficult. And then you need to think also as policymakers as to what is the environment in which you want to gather that evidence, who is responsible, what is the selection mechanism. And I think those types of very early on types of rules and regulations are often quite unestablished in many circumstances. So the report tries to increase that awareness and hopefully set some of the member states or whatever authorities there are responsible for this to make this type of progress. Because you're absolutely right, if we want to label something as a best practice, this report actually signals only one thing. If you look at the healthcare system and the goals we have, what do you want from all the separate entities in that system? That is that they contribute to that goal to the best of their ability. If you don't know that, and you do label something as a best practice or whatever label you give to it, and there can be perfectly good reasons because you don't have any better evidence, but if you're responsible also for the evidence gathering, or you could make it happen, then I think we should do a much better job in getting to evidence-based policy, not only evidence-based medicine, but evidence-based policy as well. And I don't think we are there yet, unfortunately. And we miss opportunities in many circumstances.
Okay. Yes, Lasse.
We had a previous expert panel report on the quality and safety, and then we discussed a lot of this issue of best practices, and I think the conclusion was that very often the best practices are not transferable, and I think that's very much the reason also with the digital services, that what applies in one hospital and one country is not always very easily transferred to another environment, and that's the very reason that we have to have the assessment. We have to be very evidence-based, and as in, they say, pharma trials or device trials, you should need at least 2 independent trials to show that the system is really working if you want to really expand its usage, something like that. I think we emphasize very much the evaluation and the evidence in our report, and that's a very important issue.
Other questions, remarks, reflections, observations? Yes, please. No, you wait. Yes, and now you may start.
Yeah.
Yes.
My name is Sabrina Montante and I work for the National Institute of Health of Italy. I represent here the National Institute of Health of Italy in Brussels. So, I mean, I was inspired by the question of the previous question, actually, because I also had a question on I mean, you mentioned in your report, and thanks a lot, actually, by the way, about it, about the need of advancing the methods to better evaluate the impact of digitalization on health, healthcare. And we believe that also. I mean, the National Institute of Health of Italy is involved in several initiatives and projects focusing on how to improve the cross-national collaboration, really to advance methods to advance health system and services research in Europe. So, and we also went through different practices, gathered at European level. If we find out that there is a lack of of evidence-based, collection of practices, and we're also trying to understand if the transferability of practices in Europe can actually help to avoid duplication, advance this. So, I mean, my questions to you is, how do you think, first of all, I wanted to understand more on what you mean for a European repository. And second, how do you think that European cooperation can support the advancement of evidence-based, policy in this field of research, not field of research, and how we can support the, research and policymaker interaction more, and maybe done it in a European environment can help. So, well, this is a very, big question, because I don't know if the panel can address that, because actually it's a wide question, but I would very much welcome your opinion on that. Thanks.
Thank you very much. We will try to address that shortly. I think the first issue was related to the meaning of that European repository. Maybe first some reflection on that one. And then the second is about, research and policy linking the one with the other. Yeah. Yes. Okay. You can talk on the repository? Yes.
Yeah. 25 years ago, when health systems started talking about quality, and we started talking about quality indicators, and we started turning eminence-based medicine into evidence-based medicine, there were several international collaborations on making repositories of validated evidence-based indicators. Might have been the American ARC and a heap of others. Even though this has been done for 25 years, to find measures which are applicable across different healthcare systems is extremely difficult, because let's say a common denominator that we use in these indicators is the number of deceased people / dead. You would think that this has the same meaning across Europe, somebody who died. Deceased person. When we try to analyze these things, we find out that there are people that died and have a clinical diagnosis, that died and have had a pathology, anatomical diagnosis stated. So it's extremely difficult to construct a validated indicator that can be used across systems. But what we mean by making a European repository is basically trying to construct a database of available validated measures that could be used for digital assessment. In one of the previous expert panel opinions, there was a very long list of indicators used today for monitoring the quality and performance of health systems. They are used by the OECD. The European repository would essentially earmark some of the already used indicators and see if they could be used to evaluate the efficiency and performance of digitalization and digital processes in healthcare. So that was the essence of trying to get a European collaboration on a centralized repository where the indicator would have a name, would have a description, and would have the validity stated by studies that have been done, so that people who are thinking, or governments who are thinking, or hospitals who are thinking about implementing a method, they could go to this short list and find out some validated indicators like you find in the ARC databases or some of the other repositories. So that was the essence.
Okay. Lasse?
I take the other part of your question on how the European Union or European corporations could support the development of evidence. I think it's very simple. It's just putting it's just a focused areas for research grants and so on, putting it focus in Horizon programs or whatever. I think we should need independent academic research of evaluating these and developing the new indicators. It's usually coming by research, and that just would just be funded and focused.
Yeah, just so on the first thing, I think it should include methods, development of methods, new methods, so the things coming out of all these European studies that we're trying to perform now, but also actual studies, so that other countries know what has been studied in another country, because what we tend to do also in this context is reinvent the wheel. It is nice to know, I mean, there are issues of transferability and so on, so what you find in that database might not be applicable to your situation, but to know what others have done, to see what happened there, is already a very good starting point for your own, also in terms of how you want to design a study and to how do you want to evaluate it. In terms of European cooperation, I think it is crucial that we strengthen it. I think there are nice things underway like UNETA, but when it comes to evaluating, I think it is important also to stress that to some extent there are two aspects to evaluating. One is what I call here the assessment phase, which is just about the figures, and the other is the appraisal phase that is much more also about culture and values. I think we can share the assessment phase easier than the appraisal phase. Because there are important differences across Europe in how we view certain things, whether we want to count certain things, what type of outcome measures we perhaps not even like, but at least would allow. So as long as those differences are there, I think you need to come to some kind of common core where you at least have an exchange, where you could even have an exchange in ways that are beyond what you would do in your own country, but it would help you in terms of what you would do in your own country. So try to define those things that you can share and share them in a way that is, let's say, transferable between the countries. You might even see the link between those two aspects, and in a repository, for instance, have quality checks in terms of the studies that are included in such a database, so that people also know this is a study that has been performed in a way that is correct. That would mean, of course, that you would need a third party that would be in charge of such a repository, but those are all practicalities beyond the 100 pages we already wrote.
Okay. And also beyond the 100 pages, but at the meta level, an important question could be to what extent and how our health systems in Europe contribute to social cohesion and to exchange experiences and data on that one, because I think that's what Europe as a project is in need for the future. But that was my personal view. Okay. Questions, remarks, reflections? Yes, please.
Hello, it's Ioana Psalti again from the European Alliance of Vision Research and Ophthalmology. I'm not quite sure whether this is a question or a comment or what, but I'll throw it out and you can do whatever. There is obviously a link, an implicit link between evaluation, a strategy evaluation and investment. But do you think that that could be brought a bit more forward in the paper? Because you're having a section on the payment but there is no direct or explicit link how the strategy, investment, and the evaluation will be kind of linked. And the problem is that with the digital therapeutics rising as a new subsection within the digital technologies, this also is linking to your previous opinion on the innovative payments models for payments. And we're just wondering whether, you know, maybe this is not a place to kind of to link all the other papers and the opinions you've got, but maybe it is. So.
Okay, I hear already an invitation to write the book that summarizes all our opinions.
Leather bound.
And now Werner is going to tell you how your reaction and your reflection can be integrated.
So that gave me an extra few seconds. That's how we help each other within the panel. Now, so I think it's a fair point, but it's also a point that is in some ways a bit beyond what we try to do in this particular report. What we try to do in this report is to say how you want to look at things, how you want to evaluate what you're getting at, and it's a crucial and to some extent almost difficult to separate link is what you do with that information subsequently. We hint on that, of course. We state that you have, because you need to think about, if you talk, for instance, about conditional reimbursement, which is a really nice strategy in some ways, but if you haven't completely set the rules for the exit strategy at the end of the period, then you will run into trouble. What you also will run into is trouble like real-world data and so on, and how are you going to deal with it, with the decision uncertainty. So those types of things, including the payment, because these are things that are completely related, of course. It's not just a yes or no question anymore. It could also be about negotiations about a price for specific things. Sometimes when it's lower level decision making, you know, it's not a central decision. So it's each hospital or whatever entity it is for itself that would decide, and also would decide on how to pay and how to invest. So it would take a separate mandate to completely cover that issue. But it's clear that it's a crucial one, because one of the barriers, also look at from the other side, you know, we know sometimes that there are these truly nice interventions that do not make it to the large-scale use because of the fact that our system is organized in such a way that it forms barriers rather than enablers for those types of interventions to get into mainstream healthcare. And I think we need to be very aware of those things as well. But again, it is a bit beyond the scope of what we can do.
Lasse?
I think it's an important issue, and we actually discussed about the cost issues and the market power of the big companies in a way. The practical life, we see very often the problem of this type of sunk cost effect, meaning that the digital solution is taken in a hospital or on healthcare setting, and it's not digitally mature, as you said. There are problems. Then you are asked to spend 100 million euros more to get it mature, and that is repeated a couple of times, and then you notice that the technology is now obsolete and you have to start it all over again. So this is, I think, very typical. We very rarely see really digital solutions that have evidence backing them, but it's very often the case. You claim to collect the evidence as you use it, and then we end up to this situation where you have to invest much more actually that you have intended. That's an issue where I don't have any solution except that you should have the criteria that you have to utilize before you make the investment decision, and then before you invest, you should really monitor the system in a way that whether it's worthwhile to invest it or whether you should skip it. The problem really is that the development in the digital field is so fast that it's, if you tend to have utilize a system for 5 to 7 years, you should be able to develop it in 1 or 2 years to get the benefits out, and especially the public sector and public sector executives cannot match this type of pace because our finances are bound to the budget periods, and it's very difficult to make very rapid solutions within those. So this is an issue, and I don't have any good solution how to tackle that, but we have noticed the problem at least.
I think we try to address the problem in the prioritization matrix in the most generic way. Where it helps you with strength, do it. Where it helps you with the senses, do it. Where it should help you with the intellect, be aware that it might be a very risky investment that never returns, and possibly may even corrupt the brains of people that use it. So,
are there some final questions, or is everybody satisfied with the reflections he or she could make? Okay. Then I would like to ask you to thank you very much for the way this hearing went. Everybody contributed very thoughtfully. And I want to give the final word to Alice to present the conclusion of the day and the next step and close the hearing. I have to apologize myself because I have commitments at another meeting, but I would like to thank you for being here with us once more. Thank you. And Alex, you will give now the final reflection.
Thank you very much, Jan. In conclusion, I would really like to thank all of you for going through the document. It's not literature reading, and it's not easy reading. As opposed to some previous documents, there is a rather long introduction in the issue to be aware of what actually the digital is able to do for us or not. In principle, digitalization itself doesn't create anything new. It just enables people to find a better common language and collaborate. And the collaboration can be phenomenal. We can see it. Let's talk about Wikipedia. Somebody decides to give the wiki code. That code sets off people on a collaboration with totally unexpected results. How many of you use the Wikipedia? I use it a lot of time. And it's a reliable resource, even though it's produced by people that are non-professional. It's been demonstrated over and over that if something wrong is in the Wikipedia, somebody notices, and there is a way of how to change things. And possibly we can initiate something like that in the healthcare sector too, but it does mean be progressive, but conservative at the same time. And it's not being schizophrenic. It's being, and it's not being in the middle. It's not being warm. I mean, the Bible says if it's warm, spit it out. It's to be extremely progressive at looking what other industries and what's going on in the digital, and then being extremely conservative in applying it to the people that we are trying to help, because it may have extreme side effects if we do it in our framework of providing care, and probably the most important thing which we can't even define, and that is health. We can define life. And we know that if we make wrong decisions based on a report by IOM to err is human, we can kill 44,000 people a year by making wrong decisions. But we can also benefit vast areas of people by much better collaboration. But for collaboration, we need support in unifying the language and in unifying the effort in the right directions. So it does need stewardship, it does need steering. And I think that we are fortunate enough in Europe that we have institutions about which we grumble all the time, which don't allow us to use lamps, and we have to use LED lights. But in principle, this steering is extremely necessary, and I'm sure that we can benefit also in the healthcare sector when it comes to the digitalization. And again, I would like to help all people that have participated in this report, and I would like to help you. Thank you for coming here and giving us important comments that we will work into the document. Thank you very much.
Except for your presentation, it all went well.
Yeah, sure. But that happens if you have to use two computers.
Of course.
And so what? Nobody remembers anything from it anyhow.
Well, it's now digitalized.
Yeah, it is, and that digital crap is going to run around. Pages,
Forever,
pages,
forever. It will haunt you.
torn out of the context, so it will
This
have
is
a
what
totally
they-
different meaning.
This is what they want.